So, welcome. Good morning, good afternoon, good evening, everyone. Welcome to the Global Public Health Week 2026. So we're at the 12 o'clock Central Eastern European summertime slot, and we have a very interesting talk today with the following panelists. We will be delving deep into 4 big questions on public health and about community resilience. I'm Pascal Dowling, and I'll be briefly introducing some initial slides, housekeeping slides, introduction slides, before we come on to the panelists, which you see today. And that's Priscilla Robinson and Dima. So we will obviously open up to questions towards the end, and we do have a Mentimeter in the middle before we get to the panel discussion, because what's really important is to engage with you, the audience, to pull in your insights, your thoughts, hear your questions. You can also unmute and ask us questions towards the end. When we're actually in the discussion phase, you can raise your hand, and we'll also capture any kind of questions that are coming through the Mentimeter. So it's really a great pleasure to have you here. It's a huge pleasure for all of us to be talking about this very important topic. And I think we can now get started. So as initial disclaimers from all of us as panelists, to read it out verbatim, that all items discussed and views expressed during this roundtable discussion are the independent expert opinions of the speakers and may not represent the views of their affiliated organizations and companies. So a little brief introduction about Peak 15, which Dima and myself are coming from. We're a social, value-driven, Swiss-based charitable and non-profit organization that's focused purely on public health. We describe ourselves as a think and do tank, so we work with leading academic institutions around the world, and we look to implement and pull that best knowledge and practice for community ownership for their future generations and for future resilience building when it comes to public health. Over to you, Priscilla.
Okay, I'm here from the World Federation of Public Health Associations, which is a global organization of public health associations. And we represent civil society, and we're not affiliated with any government or bureaucratic organizations at all. So we represent the views of the trained public health workforce that they may not be able to talk about in their places of work. We have 140 odd member organizations, and we represent about 5 million people worldwide. I look after a particular section of, at the moment, I look after a particular section of the Federation, a working group on public health education and training. Back to you, Pascal.
Wonderful. Thank you very much, Priscilla. So a little bit about us as the panelists. We're coming from a range of disciplines, and we will pull that knowledge together when we're discussing about these very interesting topics and questions. So I think without further ado, we can jump straight in to the Mentimeter. So what we'll do, because we want this to be engaging and we certainly want this to be a dynamic discussion, what we will ask, actually the 4 following big questions, is how to ensure knowledge capital stays in the community without trapping people in low resource environments? How do we justify investing in knowledge capital when the physical infrastructure to use that knowledge is currently being destroyed? And now on to question 4. Is there not a risk that learning ecosystems from academic insights are a soft response to a problem, needing legal and physical intervention? Right, let's jump straight back in now. Okay, so all 4 are now displayed. Priscilla, Dima, let's go one by one. So I think we start with the first one. Do communities require long-term education for times of crisis? Priscilla, let's start with
I'll
you.
start if you like. Yeah.
Yeah.
Well, because my work is mainly has largely been in infectious diseases and disease control. Clearly, everyone remembers that we had a major pandemic very recently, and I don't know whether people remember, but during the pandemic, people said often, "We will never forget the lessons we've learned during the pandemic." And I think it's probably taken people about 3 years to totally forget most of the lessons that were learned during the pandemic. So, definitely long-term education is required, and definitely reinforcement of the messages needs to be built into various systems that we have.
Mhm.
For example, at the beginning of every winter, depending on whether you're in the global north or the global south, we need to reinforce the messages about wear a mask if you've got an infection, don't go to work if you think you've got the flu, even if it's not
Mhm.
actually real flu. Those kinds of lessons, which have already been lost from the pandemic and are already um, causing noticeable blips in diseases that were absent during the pandemic. Flu being a good example, like, all of the message that we took did help with stopping the transmission of COVID, but it also stopped a lot of other things that happened quite regularly.
Yeah. Yeah. Very nice. Dima, would you like to add anything onto that before we?
Yeah, I will take it from also from COVID. We had many problems, mainly misinformation.
Mm.
Yeah,
And I think during crisis, we do not have time to shape messages that can reach and be understood, but by every target usually. So depending on their education level, on their familiarity with, for example, infectious diseases. So if on normal days we are preparing these people to understand such messages, so in time of crisis, we are just refreshing their memory. So they will be able to understand what is our message, analyze information from misinformation. We don't have luxury to do this, to do so during crisis. So
yeah,
definitely long-term education should be the time we use to prepare our audience to understand and to understand their role and also to build the trust with policymakers.
yeah,
And
Yeah.
also during normal days, because we are building trust with them, they know to which channels they should go to get their information. And that was missing during COVID. And I think you're right. We already forgot all the messages. We already forgot all the problems we faced during COVID, and we will have the same problems if we
again.
don't start real education about health topics today.
Yeah.
Actually, can I just add to that?
Please.
Because I think Dimas made a very, very important point. And I think what is very hard for communities to understand is how advice and information changes. And I think part of long-term education is to do with the issue of trust, Dima, that you clearly mentioned, and I totally agree with. I think people need to understand that as information and evidence about what is happening changes, the advice will also change. So it's not a question of people who are managing the crises not knowing what they're doing, which is how it was often presented, especially in certain newspapers and certain news outlets, but much more we need to people to understand that if we have to change our advice, then that's because the evidence has changed.
Of course. Yeah.
I often think about this kind of resilience is built in peacetime, right? And then it's activated in the crisis. And to your
Yeah,
point, I often have to reflect on the WHO Community Protection Resilience Framework. And, they run these simulations, obviously, for the moments when a crisis hits, right? This preparedness or readiness, and kind of stress testing the health systems. I absolutely agree that within the 3 years, nothing much has been heard, obviously, except the important work WHO have done and recently passed, and last year, I believe, was a kind of consensus approach to handling of a pandemic. Now, I often think about the community level because we are reliant, obviously, on the multilateral organizations, but we're also reliant on government. And the question is, controversial one, to what extent should this be integrated more in a direct-to-public approach? Because I believe the 2 points you're raising, very, very valid, extremely interesting, is really this community resilience, which is actually one of the large themes for today. Kind of building that knowledge into the community, whether it's through community health workers. And I think this speaks for every GDP level setting country, regardless, because as you mentioned, when a pandemic hits or epidemic hits, it hits. And preparedness for that is absolutely important. So how do you see this more being government-led or typical public health as multi-channel as possible, so in parallel as possible? So would you say government plus community health workers plus kind of local community-led initiatives? Be very interested to hear your thoughts on this.
Well, it's here where I live on a floodplain in a mill, and we get floods about twice a year, which cause us to not be able to leave home. And in terms of the local community, we have obviously an information channel that goes up and down the road and says whether we can get out and who might be in trouble and what we need to be able to do and who needs whatever. And that is even in the kind of 6 months between floods, we do get new people in the community, people that also don't believe the weather forecasting and so on and so on and so on. So all of those things are reinforced by local action. And we're often the people telling people higher up what is happening locally. But maintaining that kind of communication is really critical. Now, you alluded to the pandemic treaty, and the pandemic treaty is really, really important in an international agreement, well, sort of an agreement. And I think it's actually very important that both levels address what might happen in times of crises. So it is important that we have international treaties, and it is important that we have international mechanisms such as the international health regulations and so on, which help us be able to activate something immediately on a national level when a problem happens. But it's also important that local communities have a swift ability to be able to respond to things that happen. And also in terms of kind of stopping future problems, for example, not building housing estates on floodplains is a really, really good idea. Like the floodplain is called a floodplain for a really good reason. Don't build housing estates on it. They will flood. And why is everyone surprised when they do? So there are kind of that kind of local knowledge and local control over one's own environment is really quite important. But I really think you have to have things happening both ways. So I know there are sort of various versions of emergency scenarios that are tested at high levels, but maybe we should start thinking about having local scenarios that we test out, like
Yes.
things that happen out of the local village halls, the local town halls that people can participate in or be nominated to participate in, and that's something that I've never seen happen. I know,
Yeah.
Our local example is extremely local, much more local than that.
I,
So
I,
maybe there are mechanisms we can think of for doing that.
Yeah, I wanted, before I pass on to you, Dima, I just want to touch on one thing here. It's a bit controversial, but you mentioned about the floodplains.
Yeah.
And if we think about climate now, it's microclimate. You know,
Yeah.
you can have a typhoon type weather system or pattern in a small area, which leaves the rest of the town completely unaffected. So it kind of it speaks a little bit to the importance of understanding the local context, which is nothing new. But it comes back to this point about centralized health, but also decentralized understanding of health. And I feel that this is a thing that's lacking, to your point, Priscilla, because everything gets rolled up into very large numbers at a governmental
Yeah.
level. And
Yeah.
how that actually speaks to kind of really the local policy and local action is something else. Dima, I don't know what your thoughts are on that.
Actually, you both covered everything. I would just say one last thing. Yeah, we are all part of the solution. We should all be part of the solution. And Pascal, this is our target, and now we are developing two projects that we are hoping to transform the vulnerable group as part of the solution. They are the problem, but through them we will get into the solution with the local authorities also. So it can't always be on the higher level. We should all be part of the solution. And this is a more sustainable way to decrease problems.
That's actually really, really important, because there are two phrases that I use a lot in public health. And when people say, what is public health? My favorite description is the Johns Hopkins saving lives millions at a time, because you can say that between the floors in the lift when you're talking to someone that says, why is it worth anything? But there's also the phrase, public health is everybody's business. So, and that kind of really show that the both of those phrases together show how public health should be working.
Yeah, absolutely. Well, we're off to a hell of a start. That's only the first question, and we've got 3 more to go. I don't know if there is anyone on the line that would like to jump in, raise your hand, ask a question before we transition to the next big question. If not, we can also capture your questions as we go along. So for the second, how do we ensure knowledge capital stays in the community? Now, I think we were already touching a little bit on this on the first question, which was actually very nicely covered. Thank you both. So how do we now transition to this next big one? Knowledge capital in the community without trapping people in low resource environments. So I don't know, Dima, Priscilla, who wants to open up with that?
Matthew, it's your turn to go first, Dima.
Oh, thank you. A main problem facing health systems is on the workforce building block. And the main problem here is we don't have, actually, I'm going to question number 4, I think, also with this answer. We don't have legal regulations for the scope of practices of each specialty. So in healthcare, or healthcare providers do not usually, and we are talking low resources environments, so mainly low and middle income countries. Mainly in these countries, we don't have documented job descriptions. The healthcare providers do not know the scope of their practices. And here there is loss of responsibilities, and in return, also there is loss of recognition. And this is the main problem facing the workforce, the healthcare providers. They are not fairly recognized and remunerated. And this is the main problem leading to burnout and to immigration of this workforce to if they are very well trained, and this is the problem, the country train them very well, and then they go to better places where they are better evaluated and paid. So I would say, to ensure that we don't lose the knowledge capital, we should solve these two main problems, recognize them, acknowledge their role and their importance, and then give them better remuneration, respect. And in these countries also, it was very well noticed that they don't have associations that organize uh, uh, organize the or protect this workforce. So I will just say these two problems. Solving these two problems would be very helpful, because low resource environments is not only about money or financial resources. I think all countries can cover and can give their workforce what they deserve.
Absolutely, yeah. I think one example of that is, I mean, NHS in UK. You can throw as much money at it as you want. Maybe it's not the best example to pull through, particularly in this question. And Priscilla, I'm sure you're closer to understandings of the NHS there.
Love the
Than
NHS.
we are. Absolutely. But I from my part, Priscilla, before I pass it over to you, is that I would honestly say, building on what you mentioned, Dima, is it's important also to have knowledge distribution. And it comes back to this verse, well, actually on knowledge capital, and to what point is a fair or equitable distribution of health knowledge, and how far should that go? Because it interconnects with all these other previous topics on readiness, risk mitigation, let's say government inability to finance or source for certain key epidemiological um, kind of new rises, right, in numbers or diseases. So I see it as perhaps this cascade or this training model is really important, and with that kind of everyone's prioritization of the importance of health. You spoke on that, Dima, on the last part of the first question. We now know, based off the Lancet, that they term this as One Health, the interconnectedness of this, everyone being, let's say, self-empowered for their own health, which would offset so-and-so NCDs by whichever date. And it kind of all comes back to empowering the individual, right? Through technology, through kind of basic public health education training, and empowering them obviously to have a role in their community, but obviously in their own lives. And I think that there's a lot now on digital that can be used to provide that. There is still obviously there's a lot of digital platforms out there which can lead to even further decentralization of knowledge. And with that, as a point previously mentioned, regarding disinformation, misinformation. Coming onto the brain drain, I also think that governments need to, in my opinion, they need to recognize. If I think of other countries, certification is very important. Things that come to my mind in terms of first aid, community, points of contact, responsible people in their community willing to step up and perhaps be points of contact and take on that training. I think in an ideal world that we will all be to some extent empowered and have that kind of basic level training on public health, and that would certainly lead to kind of more understanding, right? Priscilla, I didn't know, it'd be interesting to hear your thoughts on that. I spoke a lot, covered a lot, but feel free to provide your context.
Oof. Well, I think you've covered a lot of ground between you. Firstly, I think I'd like to pick up on Dima's comment about recognition and registration. A lot of the work that I've been doing in recent years has been to do with, especially in conjunction with WHO, has been about, has been on a project called Securing the Public Health and Emergencies Workforce, which has had three arms to it. The first arm being defining the essential public health functions, which there happen to be 12. They happen to be the same in more or less every country. They're not always 12. They're sometimes differently organized. Basically, the content is the same wherever you go. The second part is about defining the personal attributes that people need to have to practice public health. And as I said before, it's everybody's business. Everybody does public health. Almost everybody in the world does public health on some level. I can probably think of about half a dozen people right now who do nothing on public health, but basically it's everybody's business. And the third and the second part of that work has been about establishing the functions, the things that people in public health do, rather than how they do them, because they differ according to context and where people live. And the third part of this big project has been about defining who the public health workforce is. And the public health workforce consists of three groups of people. So there's people like me that do nothing other than public health day in, day out. That's what they do all the time. The second part of the workforce is the people who are mostly in the healthcare community, but include some people like social workers, for whom public health is a small part of what they do. Well, it can be quite a big part of what they do, but they might be providing health promotion or dietary advice or helping to make sure that people are maintained in their own homes, or they might be making sure that the local communities are safe and healthy places to live. So those kinds of people. The third part of the public health workforce, the second thing about that second part of the workforce is that a great many of those people are regulated in their own work. So environmental health officers, for example, psychologists, all of the healthcare professionals all have to be registered and regulated as part of their work. The third part of the public health workforce are the people who never ever think of themselves as working in public health. So they would include, for example, engineers and politicians and people that clean our streets. And in fact, everybody else in the whole world does some sort of public health at some point to a greater or lesser extent. And if you look at the list of tasks that people in public health do, you'd be hard pressed to find anybody much in the world that doesn't do at least one of those things. It's a very long list, but it's all there. Some of those people are regulated in their own professions, some not. But the problem, Dina, that you alluded to is that people that do basic public health are not regulated in any particular way, not registered and not regulated. And sometimes that's because they don't have formal training, because most formal public health training happens in university at postgraduate level, and you're supposed to have one of those kinds of degrees to do public health work, although that isn't necessarily the case. But the public health workforce is not regulated, not registered and not regulated. And I personally wish it was. And part of my sort of current work is pushing towards making sure that all public health degrees are regulated. Side issue, after the pandemic, about almost every university put up public health courses, even if they had no idea what they were supposed to be teaching. So the content of public health courses isn't necessarily very public health oriented these days. And certainly those degrees are not all regulated and registered as public health degrees. Most of them are going to fulfill national requirements. But the people that do them, therefore, are not necessarily going to be trained in public health. So there needs to be a mechanism for recognizing public health degrees by some sort of, I've just forgotten what the word is, it's gone right out of my head, but I'll come back to it in a minute. But there needs to be a mechanism for recognizing the content and quality of public health degrees internationally, so that the degrees are transportable. And we need to think about developing a mechanism for registering the public health workforce. Having said that, and sorry, I'm going to go on for a little bit longer, is that a great many people in the world do important public health work who might not even read and write in any language, never mind, and have access to education. So we need to find mechanisms for recognizing their work. And they are people who are largely women and largely do not move out of their communities because they're women and they live in places that are quite remote. And they need to be supported to do their work and recognized for the work that they do. I can think of many examples of those kinds of people. I'm not going to put a list of them up here, but they're important in public health work and we need to support them. And that's not the same as the IT influencers in this world who are trained in absolutely nothing other than finding silly information on the internet mostly.
Yeah, and that fits nicely to Dima's initial point on the misinformation. And
Yeah.
many people are struggling to curb this problem, and certainly with the likes of big tech companies like Facebook, where all information is unfact checked, it's gone even further downhill. Yeah, I agree. Knowledge capital and actually institutional knowledge as well. Academia has still a very large role to play, I think, globally in the dissemination of that knowledge. Before I pause, come on to you, Dima, I just want to pick up on people's responses for question 2. I'm sorry for the late feed in here, but it's very important to acknowledge the good comments coming in. So for question 2, where we are at the moment, ensuring knowledge capital stays in the community. There are 3 quick comments, and I would like your thoughts on this both. We keep education as accessible as possible by making it either low cost or free, point 1. Point 2, by training the trainers to retain their knowledge and enable them to carry on. And point 3, support key knowledge keepers to stay local. Any thoughts?
I agree with all 3 of those comments. They're important comments.
Same, yeah. Yeah. And I think it speaks nicely.
Well done to the people that put them up.
Exactly. And I think it speaks nicely to finding mechanisms to ensure that knowledge stays at a community level setting. It's absolutely essential. It's all very well to import knowledge, and that's still important. It needs to continue, but I would say that the overlooked importance of retaining knowledge in communities is something which is still underserved at the moment.
Actually, I know of a nice example of keeping knowledge local. I mean, a lot of Aboriginal communities in remote Australia, where I've lived for many years. I haven't lived in remote Australia, but I've lived in Australia and helped with training, is a model for bringing students in from communities to do coursework and then go back to their communities so that they're relieved of their day-to-day responsibilities while they come in to do the learning and can take the knowledge back with them when they go back to their ordinary work. And that works really quite well.
Yeah, so to do away with the daily kind of restrictions, right? And to be focused on the coursework. Yeah, I mean, this sounds simple, but it's extremely important.
Yes, it sounds simple, doesn't it? Let's just do it. Yes. I agree with you. It's not simple and it needs funding. It's not simple and it needs funding, and it also needs support from the communities to do it. Actually, I know of similar systems that happen in rural India as well, where local communities nominate people to go for training. In fact, I know some lovely examples from India. But that kind of model I've seen work really well for keeping knowledge in the local community and expanding the knowledge of local community and basically training community leaders so that when the times of crisis happen, there are people who the community knows have done some training and can be their spokespeople and their contact points.
Yeah. And you know, one of the topics I'm sure everyone is fed up with hearing this, because the health repercussions will grow, and I guess they'll be calculated more and more in the future, is the US aid. And I think that's a really good example. You know, when speaking to people on the ground in Ethiopia, in Ecuador, in Colombia, it's always the same thing, that those outpatient clinics closed, most of them closed overnight, right? And because people were not being paid, so they would not There was nothing to turn up to. Quite understandably, they were not being paid, unable to support their families. What happens then with knowledge, which was actually dispensed with important frontline clinical care? What happens to the knowledge then? It just disseminates or evaporates in the building that's been shut, or the building that's been demolished, or the building that's and this really comes back to this original point that I always think of World Food Program actually as a good example, very different angle about the Great Green Wall in Africa, in the Sahel region, rediscovering kind of indigenous knowledge and local knowledge that's been lost for 500 years. I'm not saying this applies exactly the same in this situation, but one of the important things is that knowledge loss or knowledge loss in application can lead to obviously a aid setting reliance on knowledge. And it's kind of moving away from this to which actually speaks to community resilience. It speaks to all these different points that we've raised. And it's finding ways to do that on a slightly larger scale with the government blessing to do that. Easier said than done. And that's something, if I think about, that we need to aspire as public health professionals to convince and move populations to really seeing the importance of public health, new, but also appreciation of the indigenous knowledge that works to the local environments, and kind of gelling the two concepts together, right, for their futures. Sounds very grand, I know what I'm saying, but perhaps certainly easier said than done as an expression, but that would be certainly a dream to move towards that. Dima, I don't think yeah, go ahead, Priscilla. Yeah.
Well, I think what you're also alluding to is the fact that the US aid model and certain other country models are quite paternalistic. And we need to find we need to understand sociologically how local communities work so that they can be resilient. If you have a paternalistic model, then all you have to do is withdraw funding and it all falls over, as it's so beautifully demonstrated. I think beautifully is actually the wrong word here. Over the last year and a half, from it's unethical to do that. I mean, I can't. It's internationally that's such a awful thing to do. But it does give us a very clear lens into the fact that that's not a model that's sustainable because of its fragility, because of its because it's not locally built and locally supported.
Absolutely. And then this speaks to larger topics about this one-size-fits-all approach to community learning and education, which is absolutely, and we could speak for hours on this topic. But Dima, I want to get your last thoughts on this before we move to question 3, knowing we have
you covered everything. You covered everything regarding this point, and I think we are a bit late, so I would suggest to move directly to the.
Okay, we will do that. We'll move on to question 3, and before I pass it over, I will then address the public's comments on question 3, and then we can take it from there. So, how do we justify investing in knowledge capital when the physical infrastructure to use that knowledge is currently being destroyed? So, what came up, and I like this one, is advocate. Just advocate. And that's very important. So I won't say my comments here. I will firstly reel off the top 3. Advocate, say that we're investing in the future society. And point 3, justify by building capacity and sustainable knowledge to enable resilience. So I'll leave that a moment to soak in. Any initial thoughts? I think we just mentioned this one as well. Even though it might not be physical, let's say, demolition of infrastructure, but there are many countries where this does happen. If I think of South America as well, we think of conflicts ongoing. We think of now geopolitical situations. We think of war. we think of all the hospitals being targeted. We think of all that infrastructure and knowledge that's being lost. Healthcare workers also being targeted. So I think for me, this is infrastructure. This is infrastructure, and we know that you need to have some residual pool of knowledge to get you through a time of crisis, to get you to the next stage gate, as it were, to be able to provide access, right, to care to individuals. So when I think of physical, I obviously think of people, personnel, healthcare professionals, community health workers, non-healthcare professionals invested in health, physical infrastructure, but also the livelihoods and communities, right? It could be drought orientated. Physically, they have to meet. They have to migrate to kind of new areas. So many topics here to discuss. Dima, Priscilla?
Okay. Well, because you've just very ably illustrated how easy it is to destroy the knowledge capital, we need a different model for supplying it, so the knowledge stays with people rather than being part of infrastructure. So the people become the infrastructure. So I know if you bomb people, then you've destroyed the knowledge capital that goes with people. But we need to find different ways of making sure that knowledge stays local.
Yes.
So that if the locality moves, then the knowledge moves.
Exactly. Yeah.
These people are the ones who will be able to rebuild this physical infrastructure. Yeah. And many practices do not need physical infrastructure. Community health work can do a lot, provide a lot, especially on primary care level. So this knowledge capital is the base for everything to rebuild quickly. Yeah.
I think one very good example of that is Switzerland. So Switzerland has incredible infrastructure, a huge shortage of nurses. And that was very, very clearly on display during COVID. And it's even more quickly accelerating. And I totally agree. You can build the best buildings, have the best MRI, PET scanners, whatever you want there. But without the people and infrastructure, so without the capital, the people to drive that infrastructure, it will always fall short.
Yes. We don't need more machines that go ping. Most healthcare is not particularly expensive. Healthcare, as in sick care, and public health is not that expensive to provide. I mean, you can look at the United States. I mean, you actually laughingly mentioned the NHS earlier, but the NHS in England, we spend about half as much per capita as America does on its population. And America has a much lower life expectancy than England. So it's clearly, if you're wanting a model to follow, the NHS is the one you need to go for. And the NHS doesn't need more. I mean, it clearly needs more funding because it actually can always use more people. But any system that you like, and you can include things like education and other sort of major structures in that. Anything can always absorb more money. I'm sure the police would like more money. I'm sure we all know that our security services need more money. Everybody can always absorb more money, but it's a question of what it gets spent on. So we don't need more money to buy bigger machines. We just need more money to have the workforce available. And the workforce does need appropriate remuneration. Don't think, and I mean, certainly when I was training, which is a long time ago now, people kept telling me that you had to invest in nurses because they were cheaper than doctors. And of course, the nursing workforce that in those days was almost entirely female. So it was
Yes.
their and the justification was, firstly, it's a vocation rather than a profession, and secondly, women are married anyway, so they just, it's pocket money. And I think there is an attitude that we need to make sure um doesn't follow through on those kinds of really quite strange and misogynistic ideas.
Absolutely. Yeah, thank you for calling that out, Priscilla. That's very important. Very important. One of my thoughts goes to, obviously now with the current geopolitical situation and energy stability, and we think about how all this infrastructure will be maintained from an energy perspective, and more and more, I think we're being, let's say, in one way, let's say, nicely funneled to what we should be doing, what we should be focusing on, which is what we're discussing here, right? It's the investment in knowledge capital, it's the investment in people. I don't want to come onto this in too much details. I'd like to go on to the last question, because I would like to actually get your final reflections from all of this before we sign off on today. I know we discussed that we may actually look at this more in a topic and provide kind of more in-depth kind of outcomes from this to drive this forward, something I look forward to. And obviously, with always these discussions, these are big ideas and big responses, and how this funnels through into action at the end of the day. Time will tell, certainly at a government level, but certainly as public health professionals, we all need to do our part. So I come on to question 4, the final. Is there not a risk that learning ecosystems built from academic insights are a soft response to a problem, and that requires hard legal and physical intervention? Dima, I know you were talking about the legal component a little bit earlier on in today's discussion. I don't know if you would like to take that on.
Yeah, I will take it from health systems perspective, which is my focus.
Okay.
We need standards, and we need people to know what to do, and we need people to understand what you mentioned previously, the local characteristics of a community. And to do so, we need policies and we need regulations. We need to build a health system structure based on the development of the country we're talking, or the community we're talking about, based on the capacities of the workforce, based on the resources. And all of this can only be done through legal regulations and policies. Definitely, academic insights are very important, but these are theories that need to be adapted and documented and tailored to the local community. So yeah, there is a big risk if we keep it just, we take soft insights. This can't be a solution for challenges like the challenges we are facing in our world.
Yeah. So actually, if I can just pick up one of the questions or comments from question 4 from the Mentimeter. Of course, so training needs to be two-way. Placements are very relevant. So you speak obviously about the legal frameworks, policy, implementation. Would you also say it's bidirectional, right? Because if I think of the WHO UN Women Respect framework, and the updated Inspire framework, they show that you need a legal enforcement, but also you need the community awareness and education to go hand in hand, because without both,
of course,
it falls apart.
Of course.
Yeah. Priscilla, any thoughts on this last big question?
No, I think that's covered it, and I think we've covered a lot of these issues in earlier discussion. Are there any other comments that we need to
So on the last one,
Okay.
there is one comment. Yes, for question 4. Yes, there is, and to mitigate this, we need to consider other ways. So,
So yes, there is a risk.
mhm. And to consider other ways. I'd be actually interested, and as always, please feel free to unmute, raise your hand, ask questions. I'd be very interested to know what this means. As an example, we are looking, as Dima knows, we're looking very much at brokering knowledge capital from academic institutions. As I mentioned earlier, I'm a great believer that academia has a large role to play beyond the dusty libraries and the old lecture halls, you know, to be, let's say, their voices and knowledge should be more in the field, right, for the community use. And I'm speculating, I'm hoping that this comment relates to this. If not, feel free to unmute. Feel free to raise your hand. The other part is, I'll take that as a yes. No,
This,
I'm no, I did no to. I'm sure it's a very good comment because it does really, yes, it has a role, but perhaps it needs to be harder. Perhaps it needs to be more that comes from academic insights, and it wraps around everything we discussed today: misinformation, disinformation. How does that realign? There is one last comment here, Priscilla. It says, "Build systems that are not dependent on individuals." That's
there's
an
there's there's also an allied answer in the Q&A, which says, can we think from another perspective and call for politicians to be public health educated, because the majority of public health decisions are political in nature? And I couldn't agree with you more. Is that Keme or Wafa? Thank you for that comment. Because when we were doing our work with WHO, we definitely included politicians as being important implementers or designers of public health, or designers of policies that had public health implications. And I couldn't agree with you more that all of our politicians should have some basic public health education. Alamiri, not Wafa. Okay, thank you. Okay, thank you for correcting me. Yes, so that's I actually agree so much with that comment.
Yeah, we see it at a European level. We see it everywhere. The people sat in those positions, they carries a lot of responsibility, and that responsibility certainly extends to public health. So it's a very, very good, very good comment there. So we're in the last final 4 minutes. I don't know if there's anyone on the line that would like to ask last comments in the chat, to raise your hand, to unmute. Feel free to do so. If not, then whilst I'm talking away, Priscilla, Dima, any last thoughts and reflections before we close today's session?
Well, we've covered an awful lot of ground, and maybe Pascal, you'd like to tell our participants what we're planning to do with the content from today. Maybe that would be a good way to round off.
Certainly, yes. So we, as with always, we are people of action, right? We need to be in a world of action, and no longer soft responses and talking. I think this is already on every single stage in the world. We will obviously look to refine the thinking here in discussion and to pull this through into some white paper, which we will hopefully present at a European level or look to publish, and to extend the thinking from today beyond into kind of the greater scientific community, right, and public health community. So this is one of the aims for today. Other than that, of course, in what we do and as a daily practice, we continue to strive ahead, right, to shift the dial and the direction of thinking towards what we discussed today and the good questions that were coming in. Other than that, Dima, Priscilla, anything else to add onto this? Feel free.
No, other than to say thank you to people for their questions and comments. Sorry, Dima, I just interrupted you.
No, not at all. I also want to say thank you for everyone who's attending with us. I want to thank you, Priscilla. It was very helpful, and I'm happy that we had this session together. I'm looking forward for what we will do. And yeah, I decided to take this session from health system perspective because I know I'm with two public health specialists, so I wanted to take another angle. I hope it was helpful, and yeah, thank you.
I can echo the
Thank you.
same. Thank you, everyone, for your time, for your enthusiasm. Please continue to do the good work that you do and advocate, as came up as one of the key words on question 3. Advocate, 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 and be examples in public health. So thank you, everyone, for your time. Wishing you all a very nice week and continued success and interesting learning as part of the Global Public Health Week launched by the WFPHA. Thank you from all of us.